everyone. My name is Stephanie and I'm an emergency physician. Today, I have the honor to provide you with an emergency physician's perspective on transfusion strategies in trauma and how we deal with bleeding trauma patients, whether it's pre-hospital, in your ED, or the ICU. This will be a talk filled with practical tips, which will have a great impact on your patient's outcome. As an emergency physician, I'm not exactly an expert in coagulation cascades and clotting factors, but there's one thing that everything should bear in mind, and this is the concept of traumatic coagulopathy. This is a bit of a monster, and the understanding of it is changing all the time. But it's important to know to tailor your transfusion strategy. Basically, it means that there's multifactorial failure of the coagulation system to maintain hemostasis after traumatic injury. The pathophysiology of traumatic coagulopathy is underpinned by two mechanisms: acute traumatic coagulopathy and resuscitation-induced coagulopathy. Acute traumatic coagulopathy is driven by two things: tissue injury and systemic hypoperfusion. There are three main mechanisms underpinning coagulopathy. This is, first of all, platelet dysfunction. The exact mechanism is unknown, but it's generally accepted that platelets get exhausted by mass activation, and this can last up to 24 hours post-trauma. Secondly, activation of protein C results in anticoagulation and fibrinolysis. Protein C is part of the intrinsic clotting pathway, and activation is normal, but in trauma, it becomes overactive, preventing further clotting and higher breakdown of existing clots. And last, there's the shedding of the glycocalyx into the circulation, causing hyperonization and further fibrinolysis, leading to depletion of fibrinogen. Patients with acute traumatic coagulopathy have a mortality approaching 50%, a greater need of transfusion, and higher morbidity. And then there's the second mechanism, resuscitation-induced coagulopathy. Transfusion, and certainly resuscitation with crystalloids, causes hemodilution, hypothermia, and acidosis. These are all obviously elements of the well-known lethal triads. And why are they a problem? They decrease fibrinogen and thrombin production, reduce platelet function, and reduce clotting activity. So resuscitation in trauma should be based on either correcting the coagulopathy and preventing resus-induced coagulopathy. So let's get more practical. When should we start transfusion? The easiest to get access to are vital signs. Unfortunately, they are not a good indicator until it's too late. When a patient is hypotensive, then it's definitely bad. You also have to know that hypotension not necessarily equals a bleeding patient in trauma. It's important to match up the mechanism of injury with findings in your primary survey. Patients can have a neurogenic or cardiogenic shock, and the latter doesn't get a lot of mentioning because it has an incidence between, even if it has an incidence between 8 and 70% of all major trauma cases. Bottom line, if there isn't anything else you can find, be aware of cardiogenic shock. A new arrhythmia and hemodynamic instability should ring a bell. Another tool in estimating the need of transfusion is ultrasound. As little as 100 milliliters of free fluid can be seen, though in general, a half liter is needed for the common user. A negative fast, however, doesn't exclude bleeding. Next, there is hemoglobin as a diagnostic marker. Same story here. Hemoglobin can be initially fine as hemodilution takes a period of time. So you need at least serial blood tests to see a drop. So what we need are early markers. Lactates and base excess will pick up more subtle types of shock. Base excess will become increasingly negative with increasing acidosis. As a cutoff value for lactates, you should keep the number 4 in your heads. With a lactate level more than 4, mortality jumps up to 20%. Base deficit and lactate are strongly related. Base deficit is superior to lactate in assessing the need for transfusion. A base deficit lower than -6 should heighten the clinician's awareness that these are indeed patients and high-risk trauma patients in need of transfusion. Pre-hospital end-tidal CO2 may also be promising. A retrospective study published earlier this year analyzed 105 trauma patients with documented end-tidal CO2. Mean pre-hospital end-tidal CO2 for those who needed transfusion, surgery, or died was 25, compared to 30 for those who did not. And the optimal cutoff for this population was pointed at end-tidal CO2s of 27 or lower. Those were the patients at risk for transfusion. And despite all these risk factors predicting the need of massive transfusion, there is no universally accepted method to identify these patients. So maybe this is an area where we need gestalts. There is one study that prospectively evaluated the ability of clinical gestalts in predicting the need for massive transfusion in bleeding trauma patients. And the headline finding is that clinical gestalts is not that great, missing over 1/3 of patients who ultimately required massive transfusion. So this confirms my previous thoughts that we are not great at predicting who will require blood. For me, this means that it's a decision that I must constantly review and reassess for all my trauma patients in the resus room, taking all previous parameters into account. And my take-home message would be intervene early because coagulopathy starts at the point of trauma. So now we more or less have an idea when to start transfusing. Let's see how we transfuse. There are two main principles: hypotensive resuscitation and hemostatic resuscitation. The goal of transfusion is keeping the flow going until definitive treatment. This final destination can be interventional radiology or theater. CT scan, in my opinion, is not the donut of death, but the donut of truth. So we keep resuscitating while determining optimal treatments. As target, we aim for a mean arterial pressure of 60, so-called permissive hypotension. This meta-analysis revealed significant benefits of hypotensive resuscitation relative to mortality in traumatic hemorrhagic shock patients. It reduced the need of blood transfusions, and the incidence of ARDS and multiple organ dysfunction was lower. It's often difficult to achieve an ideal map. This is more a judgment call, but if your patient is hemorrhaging, a map of 60 is acceptable. If there is dominant head injury, you'll have to aim for a mean arterial pressure of 90 or more. So we already why we should transfuse and when we should start to transfuse. Now let's look what we should transfuse. First of all, the patient is hemorrhaging blood, not salt water. The goals of resuscitation are to restore the functionality of blood. This is completed by restoring the circulating volume, oxygen delivery, and hemostatic potential. Crystalloids address none of these critical tasks. They are only a temporary volume booster. The NICE guidelines restrict the use of crystalloids to pre-hospital use. They recommend small boluses of 250 mils at a time, and it can be considered for patients with a systolic blood pressure lower than 70, altered mental status, or loss of peripheral pulses. But if there's access to blood pre-hospital and certainly in hospital, you should give blood products. We aim for balanced resuscitation. In 2007, a first paradigm shift happened. There was Borgman who did a military study where 250 patients were involved, and they were split in 3 transfusion groups. The best mortality was observed in the high rate transfusion group with a 1:1:4 ratio, as you can see here. The landmark trial in this field is probably the proper trial. Among patients with severe trauma and major bleeding, early administration of plasma platelets and red blood cells in a 1:1 ratio compared with a 1:1:2 ratio did not result in significant difference in mortality at 24 hours or 30 days. However, they saw a significant reduction in extubation the first 24 hours. And despite the fact that the study was underpowered, it was generally considered that a 1:1:1 ratio was preferred in the trauma population. Next, there is Fibrinogen. The early administration of Fibrinogen was found to be superior to fresh frozen plasma in the treatment of trauma-induced coagulopathy. This is the RETIC trial published in The Lancet in 2017. Patients in this study were treated with fresh frozen plasma, 50 mils per kilogram, or coagulation factor concentrates. That was Fibrinogen primarily at a dose of 50 milligrams per kilogram. The primary clinical endpoint was multiple organ failure, and the study was terminated early for fertility and safety reasons because of the high proportion of patients in the fresh frozen plasma group who required rescue therapy compared with those in the coagulation factor concentrate group. These results underline the importance of early and effective fibrinogen supplementation, so factor-driven resuscitation for severe clotting failure in multiple trauma, rather than the classic balanced transfusion strategy. Another thing not to forget is calcium. Calcium is a cofactor in production of fibrin, important for clotting. It improves myocardial function. And because of the fact that packet cells contain 3 grams of citrate, so it will bind to free calcium and will prevent further clotting, this is something you should give all your trauma patients. Also good to know is that most trauma patients are already hypocalcemic when they arrived in the ED. It's something that develops very early in trauma. So you should give 1 gram at least. And then there's tranexamic acids. TXA is probably the only proven thing to give. There's one method, give it quick and give it early. I give 1 gram over 10 minutes, and basically is the most evidence-based bit of the whole talk. And this is the CRASH2 trial who looked at tranexamic acid in trauma. So what about Tech and Rotem to guide resuscitation? This is a rapid test to tell us what's going on with clotting. They analyze clot formation, clot strength, and fibrinolysis. It allows us to tailor correct blood product ratio in real time derived from a pictogram. However, in the emergency department, the marker of excellent trauma management is getting them to definitive treatments. We want to aim for a swift movement through the system. Detailed tailoring of blood products in the emergency department is not primordial and not realistic. By transfusing the right product from the start, we will avoid horrendous coagulopathy, and a more detailed catch-up can be performed in theater. There's also the Cochrane review of 2015, which shows little evidence for mortality benefits. This is also a good article which shows you different algorithms of bleeding management using Tech and Rotem. And in discussing the best recipe attempt to mimic the composition of whole bloods, why not use whole bloods? The main issues are mainly compatibility, shelf life, and the warm versus cold storage. It's well known in the military setting. However, our civilian trauma patients do not carry immediate identification of their blood type. Also, a lot of patients who are blood group O still have a significant level of anti-A and anti-B antibodies. But there's an innovative and modified form available these days and used mainly in the US. It's the so-called cold stored low titer anti-A and anti-B group O whole bloods. And this can be stored up to 21 days in the fridge. The whole blood has a lot of advantages over conventional component therapy, including higher hematocrit levels, greater platelet counts, and factor concentrations, and less additive solution as citrate compared with an equivalent volume of reconstituted whole bloods. In a single center study, they compared whole blood versus component therapy in adult trauma patients, and whole blood therapy was associated with a 53% reduction in post-emergency department blood transfusion and a 2-fold increase in likelihood of 28-day survival. So while there are certainly biologic and logistical advantages to whole blood transfusion, the stocking and processing of the whole bloods can be a labor and time-intensive task for blood bankers. And also the donors who are qualified to donate whole blood are very limited in number because they should be blood group O with a low anti-A and anti-B titers. The evidence still needs to develop further, but old might become new again. And everything I said in this whole talk, there's a great European guideline that has that also discusses all the points. And it's also because we love bundles. So after this talk, it should be easy peasy lemon squeezy. You all have now the perfect recipe for transfusion in trauma. It should be based on correcting coagulopathy and preventing resus-induced coagulopathy. You should keep in mind the final destination and its definitive treatments. You can fine-tune treatment after diagnostic testing, and don't forget whole blood. It might be promising in the future, and you might make the old new again. So this is it for now. Thank you, and if there are any questions, feel free to ask.